Today we're going to talk about multiple congenital anomaly syndromes. I've just picked out a few that I thought were instructive. Some are common and some are rare. This is half of a talk I gave to the genetic counselors that was filmed for their review board in 2012. And you'll see as we go along there's been some changes with some of the comments that were made or some additions. So let's go ahead. As you know, velocardiofacial syndrome is a very common disorder. It's probably more common than what the incidence figure says up here, maybe closer to 1 in 2,000. It's often confused with the DiGeorge syndrome, and some people prefer to use the term DiGeorge. But in fact, DiGeorge reported a number of patients, probably in the order of 6 or 7, that had some of the features of velocardiofacial syndrome, but the focus, and he was an endocrinologist, was the absence of the thymus and the symptomatology that occurred under those circumstances. Well, only a very small percentage of velocardiofacial children have absent thymuses and go through that metabolic process. And even those that do, it's fairly mild and it goes away after a few days or weeks. And there's also a gene location on the 10th chromosome, I think it's 10q, for the true DiGeorge syndrome, which has somewhat more severe facial abnormalities and certainly more severe ear abnormalities. The identification of the location of the gene here is, as you have seen it and know from your own experience. What is interesting about this condition was this was obviously around for a very long time before it was ever recognized. And the reason for that is that the facial phenotype, which we all assume is very typical, didn't look very typical to people seeing these patients. Of course, the cardiologists saw them a lot, and they paid less attention during the early years to the facial phenotype than we do now. Another interesting thing is most of these patients had truncal heart defects, like tetralogy of the below and truncus arteriosus and transposition of the great vessels. So anytime you see a patient who's dysmorphic who has those truncal defects, you need to think about velocardiofacial. We'll show you pictures that will demonstrate the typical facies, but another important thing is that they often have velo-palatine dysfunction, so they function as if they had a cleft palate, even in the absence of a cleft palate. And of course, they have the nasal twang as well because of that. As we mentioned, they do have some problems, but it's a small percentage of them actually have hypocalcemia or any thymic issues. They have an increased frequency of mental retardation and schizophrenia. And schizophrenia seems to be fairly frequent, and it's more obvious as the individuals get older. Here's a collage of individuals with velocardiofacial syndrome. And what I want to point out here is that the newborn has a very bulky nose, particularly full nasal tip. Not particularly prominent at this age, but it will become, as you can see here, in an older child. The distance between the nasal tip and the vermilion of the upper lip is decreased. And as they get older, the nose tends to lose a lot of its bulk, but the nasal tip continues to be prominent. And along with that, the ears tend to be smaller and minorly deformed, not like the true DiGeorge patients that have fairly severe malformations of the ears. And you can see here a small ear. This would be more typical for DiGeorge. This less so. This wouldn't even raise the issue. This is sort of in between. The nasal bridge is relatively high, but not enough to draw much attention to it when people describe the facial features. There's a tendency for a small mandible in infancy, but as you can see, that goes away. And there's more relative prognathizm, relative because the mandible is probably normal, but this area here tends to be flat, making the mandible look more prominent. Now, a condition that was recognized by Towns many years ago is a very interesting condition and extremely variable. The gene was identified, and it was at that point that we began to tell how variable it was. And the defect in the gene is, as you see, which has particular functions, and they've associated that with animal studies. The Imperator Anus with the thumb abnormalities is what draws attention to this particular condition, making you immediately think that it could be a Townes-Brock. Obviously, you could think of other conditions, but now that we know that this is fairly common, that is a very frequent differential. They do have some ear abnormalities, tendency for the superior portions of the ears to be crumpled. They have an increased frequency of hearing loss. They do have cardiac abnormalities, about 25%, some secondary renal defects, and as I mentioned before, extremely variable. Here's a mother and child. The child has a triphalangeal thumb, and notice that there's almost no creases, indicating that in utero this child was not flexing its thumb. The mother has a flexion crease, but only one. Most of us will have two flexion creases. One of them is usually very definitive, and the other one is faint. And you can see that the thumb looks large. In fact, stub-like thumbs are typical in some of these individuals with Townes-Brocks, as opposed to hypoplastic thumbs, and on rare occasions, missing thumbs. The ear, superior portion of the ear tends to turn down. This is a family that we saw in which there was at least 5 individuals. One of them we could not diagnose, but was an obligate affected. Here's one of the members of the family. You can see a typical triphalangeal thumb. The thumb usually has 2 bones in it, as opposed to the fingers, 2nd through the 5th, that have 3. However, it can look long because of the extra digits that are present. Here you see the effect of a thumb that's not developed well. The thenar muscle mass is hypoplastic. It doesn't develop either if you have thumb hypoplasia. And here you see that this individual has hypoplasia here, almost no thenar muscle mass, and that broad thumb again. So it's a good marker when you have thumb hypoplasia if the thumb is broad at the tip to think about Townes-Brocks. This is that family, and it took 2 or 3 visits before we were able to see who was and wasn't affected. And we never saw this family that had primarily Imperator Anus by history and nothing else. So we didn't know whether they were affected or not, but you can imagine we thought they would probably be if we were able to examine them. Now, Williams syndrome is a condition that is very famous because it was one of the first syndromes identified in the early 60s. And it was identified because it got the nickname elfin face syndrome. And that was primarily because of the eye configuration, but more because sometimes, not always, the superior portion of the ears were pointed, or more pointed than normal. It was common. At the time, there was, these individuals had increased frequency of hypocalcemia, and there were formula errors made in the 50s that caused hypocalcemia in children. And so there were some cases of Williams syndromes that were mixed up with otherwise normal kids who weren't getting the appropriate amount of calcium. It's a microdeletion at 7q11.23. As you know, it involves elastin and other contiguous genes. And the hallmark feature of the syndrome is supravalvular aortic stenosis. This Williams, maybe 50% of them are going to have heart defects. and the majority are going to have supravalvular aortic stenosis. And then there's a 5% incidence of hypocalcemia. One of the unique features, and we'll be talking at another time about diagnostic pearls, single things that can either make you suspect a diagnosis or even make a diagnosis. But these lateral supraorbital edema areas are here, and it's represented by swelling. They have the very blue sclera. Stellate irides really means that the irides are hypoplastic, so you get to see into the irides easier, and it gives a bluish color. Prominent epicanthal folds that may not go away with growth of the nose. The nose is high set, but the bridge is flat. They have a large everted lower lip and small teeth. Some of the other features that are less frequent but still useful: short stature, mild to moderate MR, hyperacusis, that situation where they are over-responsive to sound, and so if a car honks or a train goes by, they go berserk in many instances. They have a coarse voice, we call it sexy voice. They're extroverted in their personality, and very, very cute individuals. And they occasionally have savant skills, and particularly related to music. And they can play really extremely well for the degree of intellect they have. They love to sing. So there's a real behavioral phenotype in this condition along with the physical abnormalities. Here's a whole bunch of individuals. You can see the everted lip. Here's the periorbital edema here. As they get older, they lose this. So in this older individual, you're not going to see it. The nose is fairly high set on the face. You can see the stellate irides. Some will have very manageable hair, others have what we call satellite hair. It just won't lay down or do anything that you need it to do. You can see the small teeth here. Now let's go on with Beckwith Women, which is an overgrowth syndrome. A syndrome you know well because of all the cases that have interesting molecular abnormalities. It's not uncommon. Its hallmark is on phalloceles and macroglossia. Those two features occur in about 75% of patients together. That's the good news. The bad news is in the other 25%, they may or may not occur either singly or together. So you have to look for other features, and particularly other features relative to overgrowth. We know that it's an imprinting defect on 11P. There's some that are uniperonal disomy, and this condition will compare with Russell Silver dwarfism in a minute because they're sort of the antithesis of each other. It is the most common overgrowth syndrome, and it's associated with increased tumors, such as Wilms tumor of the kidney, neuroblastoma, and hepatoblastoma, as well as the effect it has on the incidence of twinning among those cases. So there's a lot of things going on. They can present in the newborn period with severe hypoglycemia. And those who aren't recognized and treated immediately have an increased frequency of being mentally retarded because of the hypoglycemia. And anytime we see a patient in the newborn nursery who has resistant hypoglycemia, then this enters the differential regardless of phenotype. You can see that the omphalocele can be any size from a slightly bigger than a regular hernia of the umbilicus, and then the neonatal hypoglycemia. These earlobe creases you need to look for. Sometimes they're subtle, but they're present more often than not. And then behind the ears tend to be these pits. That's probably a 50% frequency, but they're rare in any other situation, so they're useful. And they have a very high frequency of a facial nevus flammeus, or that pink birthmark that goes from the forehead over the eyes and over the nose. And then they have visceral megaly, and particularly the kidneys. And this is visceral megaly in the absence of tumors. Here's a child with macrodysplasia on phalloceal. He had one leg that was larger than the other. And here he is here. He added cranial synostosis, which is not normally a feature, but it has been reported. So this indicates that low-frequency features and syndromes can actually lead you astray if you're not careful. His mother, who had no other features, has the crease as well, and her sister had an affected child, male child with Beckwith Women. So when you're asking families if they have any problems that you're seeing in their child or their nephew, and they say no, then you need to confirm it by photographs and not take their word for it. Otherwise, you're going to be in trouble periodically. Steins Heavy. Dr. Heavy died a few years ago, but he was a radiologist in Cincinnati when he helped Stein, who's a developmental pediatrician in Cincinnati, who is still alive, describe this very unique syndrome. It is a single gene. You can see in 2012 he didn't even have the gene for this yet. So I had to put a question mark at that point. Incidence is very uncommon. I see maybe one, when I was actively seeing patients, I maybe see one every 5 years. So you can see that that's reflected in its incidence. The gene's identified now, and there's a second gene on 22q that's also been found in a very small percentage. These occupy 70% of the cases. The other 30% of the cases are not identified except for this gene. Almost all the cases are sporadic, and their hallmark is broad thumbs and halluces, which was the first syndrome in which that was made to be a major feature. We now know there's many syndromes with broad thumbs and broad toes, many syndromes meaning probably 20 or so. So that's not the only marker you need. You need the facial appearance as well. They have down-slanted eyes, very high nasal bridge. Their nose gets beaked in the middle portion as they get older, and they have a high, narrow palate, and it's truly high and truly narrow. They also have hypertrichosis, and this may be evident in the neonate, but certainly by the time they get to mid-childhood, many of them have excessive hair on the body and in areas where the hair would normally grow. They tend to be short, but not severely short. They have moderate mental retardation. They are very social individuals and good mimics. Heart defects are increased in frequency. Interesting that they have keloids, and this is found in the individuals who are Caucasians as well as the blacks who have this disorder, and they're very friendly individuals. Here's a collage of different ones. They are the origin of the term hitchhiker thumb because their thumb deviates laterally and outward, and the reason it does is that the bone that the thumb sits on is hypoplastic. So it sits lower, and that allows it also to deviate out. Sometimes it's more curved in its deviation, sometimes it's just straight. You can see the thick eyebrows in this girl, somewhat in this girl. She's a golfer, by the way. And this is an older boy who I saw at Mount Rainier Institute when I was a fellow in training with David Smith in Seattle. And he was walking with us around the campus, and they were just admitting a girl with obvious Steins Heavy, and he looked at us sort of wryly and said, she's beautiful. So he recognized beauty, if not the similarity. Treacher Collins is another disorder that's very distinctive, but extremely variable. It is uncommon, but when you find one individual, there's often a number of other affected individuals, usually affected to different varying degrees. The gene for this it has been identified. There is another gene which I failed to find in my search this morning for this condition as well, but it's very rare. The craniofacial features I'll show you, so I'm not going to go over these, but I'll point them out on the picture. there's enough in the way of physical features that this is one of those diagnoses that if you're brave, you can gestalt diagnose, like walk in a room and 10 feet away or 20 feet away, you'll say Treacher Collins. You'll be right 19 times out of 20. This child has very mild features of it. We knew he had it, not from his features per se, but that his mother had it as well. His ears are on the small side. But he doesn't have much malar flattening here. And he had no clear-cut colobomas of the lower lid. Here's a grandfather and his son, or a grandson. And you can see that he has this clefting right there that's typical. Small mandible. The baby looks more mildly affected than his granddaddy. And here's a more severely affected child. And here is a very severely affected child. He's had a number of surgeries. The malar bones are almost non-existent, so that there's a tremendous drooping of the eyes and downward eye slant. And the mandible is very small. He had to have a trach for most of his life. The gene, as we know, has been identified. And there are at least one other gene that can be confusing in regards to phenotype. They have very small ears. Some can be missing their ears, and many have a conductive and mixed hearing loss as a result of that. This is one of those rare syndromes where it's all craniofacial. There's no limb abnormalities. There's no visceral abnormalities. So there's not many syndromes like that. But when it's severe like this, it's really very difficult for the kids to make their adjustment and requires multiple surgeries that have varying degrees of success. The Congenital syndrome was reported in the 30s by a doctor in Europe. Not particularly common, but because it's very distinctive, almost every case that's been seen gets reported, so you have a fairly high frequency in the literature. The gene's been identified, although there is a couple of other genes that have been found, as you can see from here, that have similar but somewhat different phenotypes and different degrees of severity. They are both prenatally and postnatally growth retarded, and this can be quite severe. They have varying degrees of mental retardation, but in general, they're going to be moderate to severely mentally retarded. And then most of them are going to have some degree of microcephaly. The facial features, the synophores across the glabella of the juncture of the forehead and the nasal bridge is very typical. They have increased lash bulk and eyebrow bulk, as well as long eyelashes. They're one of the syndromes with the truly high-set nose, thin upper lip, downturned mouth corners, and coarse voice. Other features include this body hypertrichosis, variable limb deficiencies. They can actually be missing their entire limbs. They can have what we call lobster claw anomalies, or they can just be missing the fifth finger, or it can just be hypoplastic. There's an increased frequency among the aborted children, spontaneously aborted children, of diaphragmatic hernias, and they have persistent cutis marmorata of the skin. And here again is a collage of children with different degrees. This is a child with severe involvement. Note the high-set nose. Note the division and loss of digits in the mid-portion of the hand. Here's a less severely affected child, but with the same features. Here is a moderately affected child. Note how very thick the eyebrows are and the synophores. Here's an older child with very overriding synophores, the high-set nose, the downturned mouth corner, the thin upper lip. And so they are pretty diagnostic. Unfortunately, people think that any child with mental retardation who has hypertrichosis is at risk of having this condition. And that's not the case. They have to have these other features. Very few of these children won't be missing any of the features that I've outlined to you. The difference in their phenotype is only the difference in the presence of the condition as far as the degree of presence, not the absence. of features. Stickler is from the Mayo Clinic. And many years ago, late 50s, he reported some patients with myopia, with arthritis, and the arthritis was so predominant in the family he originally reported that arthritis as a major feature stuck for many years. It's actually now not a very common feature of the condition. Some people do have it, and the reason some people do have it is there's a mild spondyloepiphyseal dysplasia. If you take x-rays of these individuals, the epiphyses will be a little bit small, sometimes because of that a little bit flat. The etiology has been determined, although there's many different forms that involve the collagen genes. This is the one of the classic sticklers on the 12th chromosome. This is one of those conditions also that is a family, part of a family of syndromes, and the deletions can also cause achondrogenesis 2, spondyloepiphyseal dysplasia congenital, Kabuki Syndrome, and hypochondrogenesis. These are other forms of sticklers in which there is a particular feature that is more common or the absence of a feature. There's a non-ocular form where myopia is not a feature, and that involves the type 2 collagen defect. These are the main features. This can be so severe that the retina will detach and they can go blind or have severe visual problems. And this can occur early in life, more apt to occur in late adolescence or young adulthood. They have a flat midface and cleft palate, and the cleft palate gets them into the category of Pierre-Robin sequence frequently because they don't have a lot of other obvious features at that point except for this flat midface. Classic Pierre-Robin don't have a flat midface with their cleft palate and glossoptosis. But these individuals with sticklers can look that way except for the flat midface. If you know to suspect sticklers, you can look into the eyes and establish that there is or isn't severe myopia. The problem with that is most babies are myopic at that point in time. So you have to do it. You have to have experience in doing it or have the neurologist do it. Sensory neurodeafness is very common. As I've mentioned before, they can't have a mild epiphyseal dysplasia. Here's a child that was diagnosed as Pierre-Robin, and you can see he has a small mandible. He also had glossoptosis and a cleft palate. What you can see also is that there's a relatively flat midface, and that's more obvious here. And of course, once you see that, you get away from the non-genetic Pierre-Robin sequence to rule out sticklers. Here's an individual who had sticklers and has sticklers as an infant, who has actually grown out his nasal bridge and looks a lot different than this guy. When a bridge is flat like this in infancy, and if it grows out, which in this condition it does, it'll grow out and not look flat, but it'll be thin, and it's at the base between the eyes. Now, Smith-Lemli-Opitz syndrome is a condition, it's autosomal recessive. Not common, not rare. It's one of the first syndromes, along with Zellweger's syndrome, that taught us that metabolic issues going on in utero can cause birth defects. We used to think that the placenta protected the child who was going to have a metabolic problem at post-birth, and that's why those patients didn't have any birth defects. And we focused mostly on those children with the mucopolysaccharides in order to come up with that. But this condition eventually showed us that metabolic problems do cause intrauterine birth defects. And in fact, I would suspect that a vast majority of the birth defects we see involve a metabolic problem in utero, some of which will remain post-birth and cause problems, and some which only have adverse action during the gestation. There's a gene, 11q13, that's abnormal, and these individuals have low cholesterol. They're very hypotonic. This is one of the, if you listed the 5 most hypotonic syndromes you're going to see, this would be in the top 5. and probably the top two. And I'll show you the one that's in the top one or two next. They have mental retardation, but it is variable, although overall it's severe. Microcephaly, hypotonia, postnatal growth retardation, not prenatal very much. And you can use the growth, prenatal growth, and postnatal growth to help you in listing the features that you value in the diagnostic process. They often have 2-3 toe syndactyly, and this is usually not the borderline type, but more extensive. Hypospadias, occasionally polydactyly, and that's almost always post-axial or on the little finger and little toe side. Low severe, ptosis, very common, and some will have holoprosencephaly. Here's a child with Smith-Lemli-Opitz syndrome, and he's hypotonic, as you can see the open mouth, and what we were talking about this morning, the tinted mouth is only that way because the jaws are droopy. Here's the 2-3 toe syndactyly, and sometimes the syndactyly will involve the fourth toe as well as it does in this child, and sometimes on rare occasions it can involve all four toes, 2-5. Now, Zellweger syndrome is a condition in which it's rare, but when you have a gene in an isolate, you can get like they had in Northern Europe when this first was reported. It can be fairly common, and then you come to a place that has a lot of heterogeneity as far as the population, and it's a lot less frequent. It's a parochromal disorder. In 2012, there were 12 gene locations. I think now that it's over 16 or 17. And here's some of the ones. These, some look similar to the more frequent Zellweger phenotype, and some can be quite different or much milder, not usually more severe. And this is associated with very long chain fatty acid increases. They often have a large anterior fontanelle. They have this unusual anterior neck fat. So if you see a baby that has a thick neck, it's usually in the middle portion or the posterior portion. But to have the thick neck in the anterior portion is unusual, and that's where they have it. They have upslanted eyes, sometimes cataracts, very frequently club feet, and then it's one of the conditions of among about 10 or so that have stippled epiphyses. So the epiphyses look like little snowballs set side by side in the epiphyseal areas, particularly the knees. Here's 3 different individuals with this disorder. See the anterior neck fat? That's very typical. And then they have this large fontanelle, and they have severe hypotonia. This is more than enough to be highly suspicious for Zellweger's. And you do your x-rays, you find the stippled epiphyses. Before we had any way of testing for this disorder, it was a clinical diagnosis, and it was not a hard one, primarily because of the severity of the hypotonia and the rarity of the anterior neck fat and the large fontanelle. Russell-Silver syndrome, or what's sometimes called Silver-Russell, depending on whether you're talking to Russell or Silver, is not common, but not uncommon. It's a really interesting disorder. The individuals are quite small in utero, and they stay small post-birth. Their smallness is in weight and length, but not in head circumference. Their head circumference is usually greater than 30th percentile, sometimes as much as 10th percentile, which makes their head look large. So a lot of people in the past have been evaluating them for hydrocephalus because the head to them looked large. There's a very unusual double etiology for this, one involving the 7q mutant parental disomy of chromosome 7, and the other imprinting gene on 11p15. That makes up probably in the range of 40 to 50%, but the vast majority still don't have either of those. They have a triangular face, thin upper lip, down-turned mouth corners, incurved short fifth fingers, asymmetry frequently, more often of the lower extremities, but sometimes of the upper extremities too. They have excessive sweating in early infancy. This is thought to be due to a slight increased frequency of hypoglycemia that spontaneously goes away and is mild. They have a slight increased risk of urinary tract problems. Their IQ is normal. Here's a collage of individuals. Again, they have a fairly high set nose, thin upper lip. Note how large the head looks relative to the small facial bone structure. Large head. Here you see some incurving and shortening, actually, of the fifth finger. Occasionally that'll happen because the bones of the finger are hypoplastic, particularly the fifth. I'll tell you a story. The jockey Willie Shoemaker was on Good Morning America about 20 years ago. And he was very small, but he was a very good jockey. Won the Triple Crown one time. And they were focusing in part of the conversation on the fact that he was small. And they said, well, how small were you at birth? And he said, well, my mama could hold me in her hand. And he said, I had a big head. Well, if you look at Willie Shoemaker's phenotype, he's got dorsal silver. I've never heard anybody say that, but that's what he's got. And he said, I had a little finger, fifth finger. So he sort of just defined Russell Silver syndrome in that interview. This is the one condition that seems to be the antithesis of Sotis or Beckwith Women syndrome. One being an overgrowth syndrome and this being an undergrowth syndrome, and both involving the same area on the underpeak. And here's Sotis syndrome, it's renal gigantism. Very rarely do we see familial cases, but when there are familial cases, they're autosomal dominant in inheritance. And we had a three-generation family in Kentucky. There's no estimate for reasons I'm not sure of how common this is, but it can't be terribly rare because there's plenty of cases in the literature. The gene for this has been identified on 5q. They have both prenatal and postnatal overgrowth, although the overgrowth slows quite a bit by the time they get into adolescence. So most of them, not all, most of them are not giants as they get into adolescence and adulthood. They're tall, usually taller than unaffected siblings or parents, but usually not giants. And I say usually because I have seen very tall individuals with this. Because they're big, of course they have macrocephaly. They have mild to moderate MR, and they have poor coordination, particularly as young infants. The face is large and triangular, but not like the Russell Silver that's small and triangular. They have down-slanted eyes, open mouth. That probably represents some degree of hypotonia that persists for quite a while. Large hands and feet. They have increased risk of malignancy, particularly Wilms tumor and sacral teratoma. And I'll show you a picture in just a second of two conditions with sacral teratoma. It can be confused with Weaver syndrome clinically. A few of the Weaver cases are said to have mutations in the gene that causes Sotis syndrome, but most do not, and the clinical evidence for Weaver syndrome in those reports was not very good. Here's the sacral tumors in a boy with Sotis syndrome, and in Schinzel-Gideon syndrome, these are two syndromes that have sacral agenesis as their major tumor-associated tumor. And you can see this guy is big, and I don't know what his ultimate height is, but he was about 12 in this picture, and he was not quite as tall as I am at that point. He loved, he was a church-going guy and loved to go around to people. They said he could feel when people were having distress, and he tried to calm them down. And he was well known for that trait.
At what age do they get sacral tumors?
The Schinzel-Gideon patients can get them in the first 3 years. They vary all over the place with Sotis syndrome. X-linked hypohydrotic ectodermal dysplasia. I don't have to tell anybody in this room about this condition. The gene for this was described by Anna here. And I'm just going to show you some pictures. It is the most common hypohydrotic ectodermal dysplasia. I use hypohydrotic because these individuals may be able to sweat some. Some may not be able to sweat at all. And that has a major impact, of course, on the quality of their lives. And I think that there's been some treatment involved in these conditions in recent times. Here's a child I was called to see in the NICU at the University of Kentucky because they thought he looked unusual, which he did. They thought he had ichthyosis, which he didn't. But he did have very dry skin that left the skin looking scaly. And children with hypohydrotic ectodermal dysplasia of the X-linked variety can look like they have ichthyosis. You can notice here an unusual retraction of his lower jaw. And the reason he has that unusual retraction is that the lower gums don't have any teeth in them. So the lower lip doesn't have any support. So it retracts. And when you see that in a newborn, always examine the gums very carefully. This child is this child when he was, I think he's about 7 years old in this particular picture. And you can see the darkness around his eyes, which are not found in most other ectodermal dysplasias. It looks like a pigment problem, but it's not. You can see they have fairly large rosy lips. You can see he has hypotrichosis. He did require extra care when he went out, and at one time they had a cooling suit for him to keep him from getting too hot, but he knew to stay in the shade. He did pretty well. This guy didn't do so well and had to stay in the suit for a very long time. You can see his conical teeth, and again, the same features. These two are brothers by two different fathers. Pseudo hypoparathyroidism, type 1A. This is an interesting condition. It's an imprinted gene or GNAS at 20q13.3. It's also called Albright's hereditary osteodystrophy. If the mother transmits this, then you're going to get the full-fledged problems with the bones and with the metabolic problems with hypocalcemia, increased parathyroid hormone, MR, decreased height, brachydactyly, and subcutaneous calcifications. If the father transmits this gene, then the child who's affected will get pseudo hypoparathyroidism. He has all the physical features, but he doesn't have he doesn't have the resistance to parathyroid hormone. He doesn't have any hypocalcemia, and both conditions are the same gene. But it took us many years to figure that out. The bone abnormalities involving the hands in particular involve type E brachydactyly. Here are two different boys. Obesity usually starts in the first year of life, so that for no good reason as far as oral intake of food. And here you see one of the hallmark features of this condition with the short fourth metacarpal that causes the finger to set down further on the hand as opposed to where it should be, which would be adjacent to the third finger and right at the base of the neck. Kabuki Syndrome, not sure the incidence because it is a variable condition, but it's not common, but not rare. The gene has been identified, and there's been another gene recently that was identified in a small percentage of cases. And 80%, probably 75 to 80% of the cases are positive for this mutation. But as I said, there's been another recent gene identified. The features: long palpebral fissures, arched eyebrows, lower eyelid eversion, flat nasal bridge, short nasal septum, prominent abnormal ears, large fingertip pads, which are, again, another pearl for clinical diagnosis, short fifth fingers. They have some degree of mental retardation and some severe, some mild microcephaly, and they have, or may not have, growth issues. Their lower frequency features here, as you can see. The long eyelashes are a good clue, but there are a number of conditions, particularly those involving mental retardation in which hair overgrowth is not uncommon. They can have immune problems, and late obesity is also a feature in some. Here's a classical case of Kabuki Syndrome, the type 1 with the long eyelashes, the inverted deep mouth, hypotonia, abnormal ear formation. These individuals, on rare occasions, can get lip pits be present at birth of lower lips, which puts them in a very small group of patients who could have that. There's now a gene on the X chromosome that has been identified that causes Kabuki. And that probably doesn't make up more than 1 or 2% of those cases that previously didn't have a gene identified. And there will be more, I'm sure.
How many of them actually have heart defects?
25% approximately. Yeah, it's high enough that you listen to the heart carefully. It's in the same ballpark frequency-wise as Riverside taping. I don't think that there's a particular heart lesion that you look for. Waardenburg syndrome type 1, I think it's more common than this, but when you see a family or an individual with this, you often see a family. And the PAX gene is mutated at 2q35. The same gene can cause more severe Waardenburg syndrome 3, or what's called Klein-Waardenburg. And those individuals have marked generalized hypopigmentation and limb deficiency. The type 1s have hypopigmentation, but it's usually pretty subtle and more often in the craniofacial area. In many of these individuals, there's going to be a white forelock, different colored irides, sensory neural deafness, hypertelorism, and the type 1s always, dystopia canthorum, thick medial eyebrows, flat nasal bridge, prominent nasal tip as they get older. The type 2 is different. It has a different gene locus, and it's different only in the fact that there's no dystopia canthorum. They have hypertelorism, but there's no lateral displacement of the medial canthi. And then there's one form, type 4, that has Hirschsprung's disease and is much more severe. Here's 3 different individuals with varying degrees of the Waardenburg's type 1. Here you can see a good, this is the abnormal eye. Her normal family background eye color is brown. And this is blue, which is due to reduced pigment in that eye. Here you see a good example of dystopia canthorum. The medial canthus here should be closer to the nose on both sides. So this makes the bridge of the nose look flat when it's not. But there's still hypertelorism. And she shows you the white forelock very dramatically. It shows you the dystopia canthorum, and the red arrow marks where the normal medial canthus should be, and in this condition, here it is. And dystopia canthorum makes the eyes look wide apart. In this condition, they are wide apart from pupil to pupil, but in many conditions, they look wide apart. But the dystopia makes them look that way. When you measure the interpupillary distance, it'll be normal. Rett syndrome, again, I'm not going to go over this in great detail with you. This is something you talk about every day. But to me, when I was in training, and then for the first few years when I was a professor, we found this condition to be very interesting because these children start out looking normal and not having any major health problems. And then sometime between 6 months and 18 months, the majority are going to start to have a regression, and they start to do stereotypic movements, particularly hand wringing. They have coordination problems, spasticity, and seizures that can also occur. They will often become microcephalic, but they don't normally start out that way. They have reduced growth and no speech in most instances, no retardation. That's a question of autism, but I think at this point in time, autism is a feature, and they can have metacarpal and tarsal hypoplasia. As time goes on, usually between the ages of 4 and 7, their regression slows or ceases. So they're left where they are, but they don't get worse. There's some more severe forms of this that involve the same gene, and there's some more severe forms of this that may involve other genes. And here are the other features that we've talked about. Here are 3 different girls with Rett syndrome. What was most interesting when I was seeing cases for the first 5 or 10 patients was the fact that they looked so normal. They were very cute, attractive looking children. And to see them regress like that under those circumstances was always difficult. Over time, those change. This girl had a congenital onset, which occasionally occurs with this standard mutation in Rett's, but can occur with some of the other forms. And here's a girl who also had an earlier onset with spasticity and club feet. Allegials, uncommon. Probably a number of cases are missed. They have a mutation of the jagged 1 gene on 20p12. They have a scarcity of bile ducts, which results in some of them with jaundice. They have pulmonary defects of the heart vessels, particularly pulmonary stenosis. They often have hemivertebra of the thoracic spine, particularly the mid to lower thoracic spine. They have very characteristic facial features, deep-set eyes, posterior embryo toxin of the eyes, high triangular shaped nasal bridge, full nasal tip, and they may or may not have mental retardation. Here are 3 different individuals, and you can see that the deep-set eyes in all 3 of these individuals. You can see the triangulation of the nose, which is typical. They often will have a pointed nasal tip. Here you see a child who, if not for the deep eyes, would look pretty normal.
It's almost like the glabella comes to that triangular.
Yeah, you would say the glabella and the upper 1/3 of the nose triangulate with each other. Yes. Another fairly rare condition that's often missed is Kabuki Syndrome. It's due to mutation on an X chromosome, XP22. They have seizures, severe MR, against the corpus callosum, vulnerable speech. They can have retinal lacuna, which are punch-out lesions of the choroid. Now, why this is an important condition, besides the fact it has severe effects on the affected child, is that you can't see these features easily in a newborn baby, particularly the telltale punched-out lesions. You have to really look for them, and first you have to suspect the diagnosis. And many times these children are missed in the first 2 or 3 years of life, and they carry the diagnosis of cerebral palsy, which is not a very good diagnosis to carry since it's non-specific and doesn't really give you much information, and it's, under the best of circumstances, variable. They can have vertebral defects and rib anomalies, and a rare one will have polydactyly. And I've mentioned why the diagnosis is delayed. Here's a little girl, I think she was about 18 months at this age, carried the diagnosis of Kabuki Syndrome, of cerebral palsy, but she was this way in utero, decreased fetal movement, normal delivery, and just hypotonic and didn't progress much. And one of the diagnoses we were concerned about was a Kabuki, and when we looked at her eye, these yellow punched-out lesions or lacunae are typical for Kabuki syndrome. So those of you who look at eyes need to be good at looking at the retina, because it can tell you a great deal about certain syndromes.
In her case, how the diagnosis, why were you suspecting that problem?
Well, first of all, she didn't have cerebral palsy. Second of all, she looked normal. So we weren't looking for a dysmorphic syndrome. So when you do those things and you start to think, what could this be? Obviously neuromuscular, but she had had MRIs and stuff like that, and nothing had shown up. Mm-hmm. So about the process of elimination, you start to think, you get the very short group. And of course, any neurologically abnormal child who's undiagnosed should have a good retinal exam. And so that was what we did, which was the first good one she had. At least 9 orofacial syndromes exist. There's actually some 12 to 17, depending on how loose you are with your diagnoses. It says here only one type has a definite gene localized, but there's a gene now for type 4 and type 6, which I'm going to talk about today. It's been recently recognized. They all share the mixed polydactyly and tongue hemorrhagomas. So the polydactyly doesn't have much specificity, but certainly the tongue hemorrhagomas do, and that's an almost constant feature of all forms of orofacial digital syndrome. And some of the ones that aren't normally considered orofacial digital syndrome, like Joubert syndrome, which is another ciliopathy, is this, that can be caused by mutations in some of these orofacial digital syndrome individuals. They often have clefting, hypertelorism, high frequency of agenesis of the corpus callosum, and Dandy Walker cyst. Here's one individual who has what we thought was type 6 with hydrocephalus. Not this individual. Had these tongue hemorrhagomas, had polydactyly, and at the time I saw this child, we didn't have any molecular marker for this condition. Here's a type 1 female with the milia-type lesions on the face. She also had polydactyly. This is lethal in males under most circumstances. Okay, we're close to the end. Marfan syndrome, common. We studied a family in Kentucky in the mid-'80s that was the largest family in the world. There was over 139 individuals in the family affected. We determined this by pedigree analysis, by having a family reunion where they all came, and we ended up identifying at that family reunion 49 individuals. Remember, not everybody in this family survived, but by history, we can infer that they were also affected. And the gene for this disorder was identified from this family, as well as a couple of other families that they had at Hopkins. Hopkins sent reading pirates down, and he was involved with drawing the blood and taking him back and having it studied. This is a condition of tall, thin individuals who also have long fingers, often a pectus excavatum, and abnormal ratios for upper segment and lower segment. Most have myopia. Many have ectopic or unstable limbs. They have scoliosis. Neurolectasia, the exact frequency we don't know, but that's of the spine. But it's a good marker if you can identify. Hernias are common, pneumothoraces are common. Fourth and fifth finger contractures are common. There's a needle form which represents usually exons, I think it's 25 to 32. When there's a mutation there, they present severely at birth and often don't survive. There's been some recent reports of mutations outside of that area that did result in the severe neonatal form as well. This is part of the family that we examined over the years. This was the family that started. This is a boy who was typical Marfan's. He had typical aortic lesions and dilated aorta. And his mother, she's 5'6", she's 234 pounds. Grandmother was about the same size and weighed about the same. They also had Marfans. So you don't have to be tall, you don't have to be thin to have Marfans. If you don't believe me, ask these people. This is Marfan's, he's tall, but he's not thin. And note the prognathism, which we see in some of the Marfan's affected individuals. This is his mother. And then the more classic individuals are here, here, and here. Marfan's is a very interesting disorder because of its variability. And without the genes to help us, we might make a lot more mistakes than we make.
So did this family recognize that there was something?
Oh yeah.
Yes.
Yeah. The doctors did too, but they never got the family together. They treated the family as different families. When we took a pedigree, this went through, I would say, 6 generations and maybe 4 major branches.
And did it, I mean, was it the heart part that they recognized, or did they recognize other pieces of the body?
Primarily the heart.
Okay.
They thought being tall and thin was normal. But it's primarily the heart and the eyes. in the eyes. Here are what thin people shouldn't have is stria. And Marfan's thin people often do have stria, stretch marks. And here's a pretty typical arachnodactyly in an affected child. Here's some camptodactyly of the fourth and fifth fingers, which is a good marker. And here's more severe camptodactyly of the fifth fingers. And here's the tall or high, narrow palate of a Marfan's. This is a neonatal Marfan's, and this is a child with congenital contracture arachnodactyly. This is called by a fibrillin 1 gene mutation, and this is caused by a fibrillin 2 gene mutation. The difference between these two, this fellow will often die in the first few months of life because of severe problems with contractures. This guy will often die of dilated aortas or dissection. This condition usually does not have either ectopic limbs or congenital heart disease.
And the only thing about stuff with rock and roll, when do they have the aortic dissection? When do they have it?
It goes from a day post-birth until they're, close to 6, 7, 8 months. And they have to, they don't all die of aortic dissection, but their chances are extremely high of dying, regardless of what's done for them. Otopalpadigital syndrome is a condition involving filament A defect on XQ28. They have cleft palate, hypothyroidism, conductive deafness, mild and retardation, tree frog digits, and I'll show you an example of that with short, broad thumbs. Remember, we had another condition with broad thumbs. Bowed limbs, and there's a type 2 that's actually the same gene that's much more severe. They can have missing tibias and fibulas, and they also have a high risk of omphalocele in the type 2s, but it's the same gene. Here's a group of siblings with this. Here you can see the basis of the tree frog digits, and the bones tend to be thicker looking rheologically and lack contour. And there's often a fusion of some of the carpal bones in this condition. And here's a type 2 with contractures, omphalocele, tree frog digits, some hypoplasia of the fibula. But again, this is a mutation in the same gene, just giving a more severe phenotype in this particular child. Last slide. You guys have been good. Incidence 1 in 60,000, so it's uncommon. It often isn't diagnosed until adolescence or adulthood, or not at all, until someone gets basal cell nevus, or multiple ones, and starts to show more obvious signs of this condition. There's a high risk of basal cell carcinoma, usually not in the first, I would say, 10 years of life. There's also an increased frequency of medulloblastoma and ovarian tumors. They have large heads, large prominent forehead. Along with that, they have hypertelorism, flat nasal bridge, jaw cysts, which usually develop late childhood and adolescence. And these often cause pain, and it's the first clue sometimes that they might have this condition because jaw cysts are unusual. And jaw cysts are very common in this condition. If you take an x-ray of their skull, the membranes that separate portions of the brain, one from the other, can and often are calcified. They have the unique features of palm pits. Their polydactyly can be preaxial or postaxial or both. Some degree of pectus, typhoid ribs, occasionally cleft lip and palate. They've got a myriad of things, even though most of the individuals look normal. Here's a boy with some lesions here. You can see the fairly large head. You can see the calcification of the thorax here. This individual had thumb abnormalities, which is a low frequency feature. And here are the prints, palm prints, or pits, that occur usually in late childhood or early adolescence. If they occur, it's not 100%. So this is an interesting condition. We had a patient where there was a very dysmorphic group of features. We didn't even suspect this disorder until the jaw cysts were recognized. I think she was like 12. And at that point, the dentist called us and said, look, your patient has jaw cysts. Have you thought about basal cell nevus? And we hadn't. We knew where the gene was located. She'd already had standard chromosomes. And once we knew where the gene was located, we could focus in on the 9q, and we found a microdeletion that had been the basis of her difficulties. So, thank you.